Alcohol use and intoxication. Acute alcohol intoxication is associated with traffic accidents, domestic violence, and both homicide and suicide, as well as a number of other health conditions. Excessive alcohol consumption is the third leading cause of death in the United States. More than 85,000 people a year die, with death being directly attributable to alcohol. Alcohol is mostly absorbed in the duodenum and in the stomach. It's metabolized in the liver. Clinical features of alcohol intoxication include slurred speech, nystagmus, disinhibited behavior, incoordination, unsteady gait, transient, which is temporary amnesia, and also stupor or coma in very severe cases. Hypotension and tachycardia can also happen because of peripheral vasodilation and volume loss. Acute alcohol intoxication could also cause hypoglycemia, hypokalemia, and hypocalcemia, and it could also lead to a condition known as alcoholic ketoacidosis, which I'll talk a little bit about later. Um, Alcohol can mask the features of many other health conditions or injuries because of its effects on the patient's mental status, and it limits the amount of past medical history or pertinent information that the patient can give you. And it's also very frequently associated with traumatic injuries like falls, um, car accidents, and such. So the diagnosis of an altered mental status as being due to alcohol use is always one of exclusion. That's done to not miss the presence of a more life-threatening condition like hypoglycemia, hypoxia, hypothermia, and or head trauma. In addition, alcohol has an inhibitory effect on the central nervous system, causing a cognitive impairment which can make the patient or place the patient in dangerous situations or circumstances, increasing the likelihood of injury. Alcohol causes peripheral vasodilation, which raises the likelihood of injuries from exposure to extremes of temperature. This peripheral vasodilation causes a loss or an excessive loss of body heat, uh, making patients feel warm, which makes them more likely to find themselves in outside in the extreme cold while not being prepared for it. Thus, hypothermia should always be ruled out in intoxicated patients, especially in those found down outdoors in the cold. Same goes during times of severe heat. Patients should always be assessed for heat stroke. In EMS and emergency department settings, mild to moderate intoxication um, is not directly treated. Treatment is focused on the exclusion of other injuries and illnesses. Any sort of treatment for addiction or anything like that, referrals to psychiatric help should definitely be made. In the presence of severe intoxication, the patient's airway must constantly be reassessed to ensure their ability to maintain a clear airway and prevent aspiration. Patients with very severe intoxication may require airway management. Um, Patients with evidence of volume depletion and or hypotension should receive IV fluids for rehydration. So these are a couple of conditions that are associated with excessive chronic alcohol use. Wernicke-Korsakoff syndrome is composed of Wernicke's encephalopathy and Korsakoff syndrome. These are two distinct but related conditions that are caused by the excessive and chronic use of alcohol. Wernicke's encephalopathy is an acute neurological condition. It manifests by the presence of encephalopathy, oculomotor dysfunction, and gait ataxia. So, profound disorientation, indifference, inattentiveness, along with nystagmus, which is disorders in the movements of the eyes. So, horizontal gaze palsy or vertical gaze palsy. Korsakoff syndrome is a chronic condition that follows the onset of Wernicke's encephalopathy. That's composed of both anterograde and retrograde amnesia, but only with the loss of short-term memory. Long-term memory is not affected. Wernicke-Korsakoff syndrome is due to an acute deficiency in thiamine levels. Alcohol impairs the metabolism or the production of thiamine, causing neuronal injury by inhibiting cellular metabolism and causing a breakdown of the blood-brain barrier. So, alcohol as well as benzodiazepines are two of the main substances that their withdrawal syndromes or being in withdrawal from them could cause fatal outcomes. That's because alcohol use enhances inhibitory tone and inhibits excitatory tone. Alcohol dependency causes the adaptation of CNS responses at a consistent inhibited level. Then the abrupt cessation of alcohol causes the body to jump into hyperactivity by not having the substance that constantly inhibits it. Withdrawal seizures start between 6 and 12 hours after the last drink. They're different from status epilepticus. They occur as a brief flurry over time, and there's almost always restoration of level of consciousness in between, treated with benzodiazepines like other seizures. Alcoholic hallucinosis, that's different from delirium tremens, which I'll talk about in a second. They occur earlier, between 12 and 24 hours after the last drink. Delirium tremens starts between 24 to 48 hours after the last drink. And these are usually visual hallucinations, and the patient is usually aware that they are hallucinating. Delirium tremens, that occurs in about 5% of patients experiencing severe withdrawal. It consists of hallucinations, agitated delirium, tachycardia, and hyperthermia. It starts between 24 to 48 hours after the last drink, and it could last anywhere between 2 to 5 days. These patients are usually hypotensive due to an increased sympathetic tone, and IV fluids are indicated for this purpose. Severe agitation is always treated with benzodiazepines. Finally, alcoholic ketoacidosis results from the volume depletion caused by sustained alcohol use, leading to an increase in sympathetic tone and a excess in the ratio of glucagon to insulin. With inadequate intake alongside that, this increases lipolysis, the breakdown of fats, leading to acidosis. This could happen in any patient who goes through a long-term or a short-term or long-term use of alcohol, consistent, such as binge drinking over a few days with very little fluid intake. In these patients, the serum glucose could be low, normal, or elevated, but it is almost always below 275 milligrams per deciliter. Anything above should lead to a suspicion of diabetic ketoacidosis.